Hello, and welcome to another episode of Vein University Grand Rounds live podcast. Today, I'm going to step in for Dr. Lowell Kabnik. My name is Omar Esponda as your host. Our co-host is Dr. Victor Canata from Paraguay. And today, Dr. Tobias Hirsch will address a nuanced and increasingly relevant question in modern venous intervention. Should a non-refluxing anterior saphenous vein be ablated concurrently with a refluxing saphenous vein? As anatomical understanding evolves and recurrent patterns become clearer, this topic has sparked debate among phlebologists, and Dr. Hilsberg explored the clinical rationale, anatomical considerations, and evidence-based perspectives that inform this decision. Also, as discussants will be Dr. Natalie Asher from New York and Dr. Satish Vajavegula in the States and Texas. Welcome. Take the floor, sir.
So, ladies and gentlemen, I'm very pleased to have you on the afternoon here in Germany on the screen, and it's always a pleasure for me to discuss this question. As you all know, we have a lot of tools in our toolbox: laser, glue, radio frequency, and they all work great. But the thing we have to think about is strategies. We need to find the right strategy for our patients. And I want to talk about the idea to ablate the ASV at the same time when we do a GSV ablation with our patients. And there are three reasons I want to give you why I would recommend to do so. The first thing is the anterior saphenous vein is not a tributary. Instead, this is a special vein comparable to a truncal vein. And so the name changed from anterior accessory vein to anterior saphenous vein. There is a serial with 4 parts published in both phlebology and also general vascular surgery, venous and lymphatic disorders, who only dealt with that special anterior saphenous vein. And the authors of part 3 of this serial asked the question: should the normal ASV, the ASV which is competent, be treated in patients undergoing GSV ablation? And they hopefully refer on a special trial we conducted in Germany, the SYNCHRONOUS trial. There are 3 points why we should take into consideration ablating the ASV at the same time, even if it is not incompetent. The first thing is the following: the ASV has the same clinical importance as the great saphenous vein. We know that from many papers. These are only 2 of many papers that show that the refluxing anterior saph demonstrates similar clinical severity when compared to the refluxing great saphenous vein. And we have that huge register from the American Venous and Lymphatic Society, including more than 6,000, almost 7,000 patients, and they concluded the ASV is more than a tributary vein and should be recognized as a common pattern of primary reflux. Oh, sorry. Do you see my presentation still? So the ASV is more than a tributary vein and should be recognized as a common pattern of primary reflux disease eligible for intervention like other common patterns of venous reflux disease. So this is not a side branch. This is a truncal vein which can also cause venous leg ulcer. The second point is the ASV is a major cause of recurrence. Here we have typical images where the ASV is the source of recurrence. You know, all images like this. These are all patients who already underwent a great saphenous vein treatment. And what we see are big recurrent veins caused by the anterior saphenous vein. And here are some papers that show us how often we can find that. Here is a paper from 2003. This is already the stripping era. This is before we started with endovenous techniques, and they saw in 43% of the cases that the lateral accessory saphenous vein, this is the former terminology of the anterior saphenous vein, was the source of the recurrence in this group, 43%. Here we have one work from 2016, recurrence patterns after endovenous laser. And we see that new truncal reflux plays an important role, and the ASV is the most important reflux source who became recanalized. And here we have another paper, factors associated with recurrence of varicose veins after thermal ablation from 2014. And they also saw 24% of recurrences from new reflux of the ASV. So 1 in 3 cases of recurrence is caused by anterior saphenous vein. And recurrence matters. We know that from that publication from the UK, that patients are extremely concerned by the probability to come back to the doctor to get another varicose surgery. Preventive ASV removal reduces the rate of recurrence. And this was the endpoint of the primary endpoint of our trial, the SYNCHRONOUS trial, impact of synchronous prophylactic treatment of the anterior accessory saphenous vein, etc. And secondary endpoints were complication rate, saphenous vein, and also the competent ASV. Competent ASV was the main inclusion criteria. You see that all GSVs underwent flush ablation, and we included the patients to the study group.
Aber auch, jetzt bist du weniger bei ASV, aber wenn man natürlich beides macht. Ja, schon
Sorry?
Schreibt doch keine Kategorie. Wir haben noch eine Hilfe.
Look, they need to.
Are there technical problems?
Go on, sir.
Can I continue?
Yes, sir, please.
Was there a question? I couldn't understand that.
I think it was an open mic.
An open mic. Oh, well, okay. So you see, ASV competent was the main inclusion criteria. So, and here we have the baseline characteristics. And what you can observe is that what you can see here is that we also observed the several types of SFJ, because the anatomical conditions of the SFJ play an important role. Subgroup analysis will show that, but at the moment I don't have the result of this subgroup analysis. And here we have our primary endpoints. This is our study group. And you see that we have an occlusion rate of the GSV of 97% after 1 year. This is comparable to all the trials we know. And what we can see here is in that group, we ablated the ASV, and also in these cases, we see some recanalization, and we see recanalization with reflux in less than 1% of cases. This is in comparison to the standard treatment, where we have the same GSV occlusion rate, but we see after 1 year that already 13.65% of the ASVs, which were formerly competent, have developed recurrence. And these are the 3-year results. We have 3 years results of a small number. You see that is still not completed, but we can see that we see reflux in 6.5% of ASVs in our study group, whereas 1/3 of the ASVs we did not treat have developed reflux after 3 years. So this does not mean that they have already clinical changes or complaints after 3 years, but we can be sure that in the future these patients will, a part of these patients, a relevant part of these patients will develop complaints and problems. So here we have a subgroup analysis after 1 year. We have then divided the ASVs in our control group into 2 groups. And what we see is that the diameter matters in patients where the ASV was in the index treatment less than 2 millimeter of diameter. We had less than 5% of reflux after 1 year. Whereas in ASVs with a diameter more than 2 millimeters, we had almost 14% of reflux after the first year. When we do such a prophylactic treatment, and this is the point of discussion always, are we allowed to treat a healthy vein? And we can discuss then afterwards. But the most important thing is that we don't harm our patients when we do that. And that's why we started our publication with a spin-off, and that spin-off was the safety of our SYNCHRONOUS patients. And the most important numbers are the P. And what you can see is there are no significant differences between study group and control group. What is the third point? The third point is the ASV has no importance as a graft vessel, and this is very important. We would not treat a healthy GSV if we have a primary ASV incompetence, because there the situation is a completely different one. But the ASV has no importance as a graft vessel, and that's why we are allowed to do that. So I want to conclude, after 1 year, almost 14% of untreated ASVs have reflux, but less than 1% of the ASV in our study group, where we treated the GSV and the healthy ASV. After 3 years, even 1/3 following standard treatment, but 6.5% in our study group developed reflux. When a preventive ablation of the ASV is being considered, it can be stated that there is no increased rate of side effects. So, to summarize, prophylactic synchronous ablation of the ASV reduces clinical relevant recurrences without harming the patient, no increase of side effect, no loss of a graft vessel, and should be taken into consideration when it comes to GSV ablation. Thank you very much.
Thank you, Dr. Hirsch. I don't have any any questions from the chat, so therefore I'm going to take to Dr. Asher for her questions.
Good afternoon. It was a great presentation, and I'm totally convinced, I was convinced before, that we do need to treat accessory saphenous vein, and it is symptomatic, it does bother patients, and we see this recurrence over and over again. The biggest problem for United States, and especially, let's say, I could tell by our practice, is how to get approval for accessory saphenous vein treatment. Because although in the studies that you reported, they mentioned that up to 68% of insurance carriers cover treatment of anterior saphenous vein, of these, 62% only covered after we treat gray saphenous vein, provided it meets the criteria of symptoms, recurrency, diameter. It has to be at least 3.54 millimeter, even for Variedina ablation. It has to be more than 5.5 millimeter for any thermal ablation. And obviously, we cannot treat them at the same time because we are restricted by insurance carriers. Like, how do you go about this in Germany? And is there any hope for us?
Yes, that's interesting, but I think in that case we have completely different conditions for the reimbursement. So in Germany, the thing is that we don't get it. We don't get more reimbursement when we ablate the ASV at the same time. we treat not a single vein, but we treat a disease. The disease is varicose veins, and this is what we get paid. And in Germany, there is a history of a tradition where we did not do a high ligation and stripping, but the standard was the crossectomy. And the crossectomy always included also the ablation of other tributaries that could be seen in the groin. And that's why we have a little different approach in Germany than you have in the US. This is one of the things. And so we do not get an additional reimbursement for that. On the other hand, it takes the user another 5 minutes or less to insert a needle and a fiber into the anterior accessory vein to ablate it at the same time. This is not a matter of time, and but there is no special reimbursement for that in Germany.
Thank you very much. I have another question. We all know, and we act upon. We were working on the varicose veins, knowing that it is a systemic disease. We keep telling the patients that it's going to be with you for your lifetime. It's not just like, well, I also tell my patients, it's not just the one vein that we need to treat and you're fixed for life. Your veins are made from material that is stretchy, and no matter how young or how middle age or how old you are now, it's going to be always getting better throughout your life, no matter what you do, no matter what we do. But still, the patients have the hopes that we fix the veins and then they're done and everything is going to be wonderful. So we have the subset of patients, I'm sure every one of you or everybody in the audience have that, comes either from after having procedures done with you 5, 10, 15 years ago, or after having procedures done somewhere and tell, before procedures, I had these veins closed, I had the saphenous vein closed, or whatever the veins were ablated. Everything was fine, and now I have these veins. I didn't have them. They keep coming, the varicose, reticular, spider veins, and they are not even in the distribution of the accessory saphenous veins. They could be in the ankle, in the leg, anywhere in the leg. And they keep saying that before the procedures, I didn't have them. Now I have them. It's because of the procedure I have them. So here comes the medical legal question again for United States. I can obviously take extra 3-5 minutes, cannulate accessory saphenous and close it. I could even convince the patient to sign consent for it. But since we have no guidelines by which we have to act, how am I going to justify in the future if the patient comes and starts, brings a lawsuit saying, I didn't have the varicose veins, now I have, I'm depressed, I'm about to jump off the roof, and they closed the vein they did not need to close. How do we go about that?
Yes, I think this happens not only in the US, we have that in Germany as well. And the point is patient information is the most important thing. And so I would say 1/3 of my patients presents with recurrence. It can be recurrence from 2001 or from 1995 or whatever. But I see a lot of patients with recurrence, and they all wonder about, oh, I had already a varicose vein treatment and they stripped it and they removed them completely. But I think in that case, it was just a poor information for the patient. I think it's necessary to inform the patient about that it is a chronic disease and it will come back. And we do our best with the best devices and with the best strategy, and we do that according to the guidelines. But the take-home message for the patient when he comes the first time should be: we can treat you, we can help you, we can remove your tributaries, we can make the skin better for you, we can heal the ulcer, but we cannot treat your type of skin, we cannot treat your lifestyle, and we cannot heal that chronic disease. We can't just treat it. And this is necessary to make clear for the patient so that he knows, okay, the doctor is going to do his best, but recurrence can happen, and then I think he was a good guy, and I will come back to him in the case I will get a recurrence.
Thank you very much. I'm gonna pass the podium to Dr. Satish Vengagul.
Thank you. No, excellent presentation, and Dr. Hirsch, I would agree in my experience, and it's anecdotal, obviously, but having done thousands of these, the recurrence rate for the accessory saphenous is probably very close to what you reported in your literature, just from my experience with my patients. You know, being in the United States, being the most litigious country in the world, and having quite a bit of oversight from medical boards in certain states that are constantly looking at how practitioners are performing treatments. Treating something that is technically normal is frowned upon in a lot of places. And so I do think that there is definitely benefit to your approach. And if you can do it, I think it's probably in the best interest of the patient long term. But given our situation here and how it is in the United States, have to approach it from the standpoint of it's a chronic disease. You'll probably have some recurrence as time goes on. We will periodically evaluate you. We'll do an ultrasound if you start to have symptoms. If you start to have, documented reflux, then we can go ahead and address it early before it becomes more progressive and causes more of the skin changes and other issues that can happen. But no, I think this is the start of publishing this type of data is something that we could work towards, maybe changing the guidelines. And once we have that, then we might be able to make some headway in the United States towards being able to address it preemptively, as opposed to waiting until it's a problem.
Yes, and that's why I was so happy when I read that 4-part serial, because both fit very well together. On the one hand, we have understood that the ASV is more than a tributary, that the name accessory vein underestimates the importance of that vessel. And we at that time we have already included the majority of our patients, and I'm sure that will change some things. But on the other hand, it is a worldwide phenomenon that the things we do, that the approach we treat our patients is not always the medical or technical best that is possible, but it depends also on other conditions. So you have in the US the endovenous techniques as the first line treatment for GSV. In Germany, the situation is completely different. In Germany, we have both open surgery and endovenous techniques as first line, but a general reimbursement is only for open surgery. And we have around 150 statutory health insurance companies, but not all of them cover the costs for laser and radio frequency. And so my first question is, once I have made the diagnosis, and once I have understood the disease, where is the reflux coming from, and which are the complaints from, and things like that, the first thing is, who is your who will cover the costs? And then it depends which tool I take from my toolbox, the knife or the catheter. If I could do it, I would always use catheters, because I have understood, we have understood, you also, and the guidelines have understood that endovenous techniques have more advantages for the patient than open surgery. But if it's not covered and the patient is not able to cover the costs out of the pocket, so we have to use a second line treatment, in my opinion. And this is not second line due to the medical state, but to the reimbursement situation. And there are other countries where there's no reimbursement at all for that, and so we then have to make compromises that we should not do, but on the other hand, we have then other tools in the toolbox to treat the patients according to other rules then.
Dr. Tobias, Dr. Hirsch, if I may, when it comes to an ASV that it's refluxing, it is not only understood that it has to be ablated, depending on size and anatomy. But what about that ASV that may have an epiphyseal segment where the very proximal part of the vein is still competent, however, that more distal part is varicose? Would you ablate the vein, or would you just phlebectomize the area that's epiphyseal, for example, and wait and see?
I think this would be a good option, and according to the ASV idea, this could work. But I think I would do probably in that case I would do foam sclerotherapy of the complete ASV, starting from the junction. Even the terminal valve is competent, but I would ablate that and would occlude that using foam sclerotherapy, and would continue with sclero the whole epiphyseal superficial branch. You think such a branch, the vena circumflexa femoris, yes, you think to the lateral thigh then, and to the lateral knee. Do you think of this aspect? One thing is important. There are a lot of connections to the GSV, and so we need to find out, is this side branch only connected to the ASV or also to the GSV? Because it's possible that we have a terminal valve competency of the GSV, but the pre-terminal valve and all the distal valves are destroyed. And then you will not have valsalva transfer of the blood into the GSV, only in the ASV, but with a distal provocation maneuver, with the A sound, you can then see that the GSV has also incompetence. And then it is not just a single ASV disease, but is a disease of both of the ASV and an incomplete GSV reflux at the same time. So it's always necessary to examine the entire GSV from the ankle up to the groin.
I am sorry to interrupt you. I have another question here from the chat. Dr. Cecilia Urestra would like to know if you analyze separately patients with saphenofemoral junction reflux versus those without reflux, could it be possible that it can determine a bigger percentage of recurrence or not? Understanding that the size of the saphenofemoral junction is maybe a higher, an indicator of risk for recurrence.
It is. So, but I have not understood the question, to be honest.
So, the way the question is structured, my understanding from the question is that after you ablate the great saphenous vein, whether or not you should ablate or recurrence would be determined by the size of the saphenofemoral junction and not necessarily by the size of the ASV, as you pointed. So,
yes. I think a proper analysis of the hemodynamic conditions at the junction is always crucial. And so what we need to know is, do the valves work or not? Is the terminal valve working in the GSV and in the ASV? Where is the pre-terminal valve? and then we think about the diameters. For the venous hypertension, the diameter doesn't play the role. It's only a matter of size at the junction, but only with respect to the technical opportunities we have. So if we have a very wide diameter of the GSV or ASV, doesn't play a role. If our target vein has a wider diameter, we have to think about, is this possible using endothermal treatment? Or in some cases, you can also take into consideration to do a ligation then. Or is this not a proper treatment? And then the next step is to think about which device to take. There are some, I think, some advantages with laser if you have such big diameters, because you can apply more energy, and so the shrinkage process will be a little bit harder.
Dr. Hirsch,
yes?
I'm sorry, for the sake of time, I have to cut you higher. It's 12:30. However, bottom line is that chronic venous insufficiency is chronic by definition. And I guess that whenever we treat the patients, we mean well. And in your area of the globe, treating like that makes a lot of sense. In our area of the globe, we have maybe less opportunity to do so. But then again, thank you so much for a very elegant discussion. And thank you, Dr. Asher, and thank you, Dr. Vallegulat again.
Thank you. It was my pleasure.
Thank you. Have a great day.
Bye-bye.
Have a great day.